We'll go ahead and record the lecture. We're going to go through each wave and talk about what's normal, what's abnormal. And then we begin with atrial arrhythmias. And the word arrhythmia means abnormal. So we're going to go through atrial arrhythmias today during the lecture. How do we get the chat box up? You guys can still see to write?
Yes.
All right, so assessing waves. When we look at a P wave and we see a little blip go up, we know that the atria are depolarizing. But what if the P wave looks weird, or every P wave looks different? Why aren't they all the same, and why don't they all have the same look? So here's just telling you it'll be upright in lead 1 and 2, and it'll be upside down in lead 3. Biphasic means part of the P wave is above the baseline, part of it's below the baseline. So here it's showing, I'm going through the slide upside down, I guess. At the bottom, it's showing how a P wave can be really tall and rounded, and there's no explanation for why. A peaked P wave comes if the right atrial pressure is really high. So if somebody has right heart failure and there's high pressure or hypervolemia, they're going to have high pressures in the right atrium. That's going to make their P waves look peaked. Then if you see a notch on the P wave, it tells you that the right atrium and the left atrium are not depolarizing together. They're depolarizing a little bit separate from each other. So looking at the P waves on here, you see how they're upside down. So when P waves are upside down, it tells you that instead of the SA node starting the depolarization, the impulse starts at the bottom of the atrium and works its way back up to the top. And when it does that, it looks upside down on the EKG tracing. So an upside down P wave tells you that the atria depolarized bottom to top.
Is this going to be from the lead 1 or lead 2?
Lead 2. So if the P wave is inverted, that means it depolarized from the bottom of the atrium and then spread to the top of the atrium. Sometimes we don't see a P wave because the heart rate is so fast that it's hidden behind the T wave. So we don't always see a P wave with fast rhythms. And sometimes there's just no P waves. All right, the next wave is the QRS. Why is it so much bigger than the P wave? And the answer is there's a lot more muscle in the ventricles compared to muscle in the atria. So the more muscle mass you have, the bigger the deflection. So QRS is a lot bigger than the P wave. And with the Q wave, it's the first negative deflection from baseline. And it says sometimes absent. Let's look at a picture of the QRS. All right, so this picture of the QRS doesn't show any negative deflection from the baseline before we see the R wave. So there's no Q wave here, no Q wave here. Some of your strips had Q waves last week when we were looking at them. The R wave is the first positive triangular deflection, and the S wave is the first negative deflection. So we call this the Q. I'm sorry, we call it QRS. And if we break it apart, the first upper deflection is called the R wave, and then coming down is the S wave. We call it QRS, or we refer to it as the R wave. So I don't know how important it is to know the technical terms, but that's where it comes from. Did I do everything on that slide? R wave, S wave. J point, I don't require us to know the J point, because to me, it looks like they're just figuring out a spot to say, hey, that's the J point. When you go from the end of the QRS into the ST segment, they're pointing here. Why are they pointing here and not down here or up here? So since it doesn't make sense to me, I don't require it from you. So the QRS happens within 3 little boxes. I think yours were mostly like 1 box, maybe 2 boxes that we saw. So that's a normal QRS. If it's wide, that tells us it's abnormal. So the second bullet says if the QRS originates from an ectopic focus in the ventricle, the complex is wide. Ectopic means an abnormal area. So I put in the chat, the ectopic focus is an abnormal area that is initiating an impulse. So when this abnormal area initiates an impulse, usually because it's irritable, we're going to go through reasons why this happens. But when the depolarization spreads throughout the ventricles, it's going to spread, but it's going to cause a wide QRS. So that's how we can look at the EKG and say there's an abnormal area initiating an impulse, because we'll see the QRS is really wide. And really wide is more than 3 boxes. So when you're looking at the pictures, doesn't it look pretty obvious that you're looking at abnormal QRSs? So usually they're pretty obvious. All right, and then it says list 3 reasons why the QRS complex will be wider than 3 small boxes or 0.12 seconds, even if the impulse originated in the AV node. So reason number 1. Is infarcted tissue. So when muscle tissue is lacking oxygen, it becomes ischemic. And if it lacks oxygen for a longer period of time, the muscle actually dies. And when heart muscle is dead, it's called infarcted. So dead muscle tissue is infarcted tissue.
So if someone has a myocarditis,
If they have an infarction, they have dead muscle tissue in their heart. Yeah.
then wider QRS complex would indicate that.
Yes.
How long would that take for the tissue to die?
Oh, good question. Could it be a matter of minutes? Could it be a matter of hours?
Something that happens like immediately, like when they're having a heart attack, or it's something that takes a couple hours or days?
Yeah, I would imagine it depends on collateral circulation.
Yeah. We've had people with Stemis come in and just in the beginning of continue to produce quite a few QRS and that's the elevation. It's not enough. It doesn't happen frequently. Sometimes some people have massive heart attacks. It depends where the block is. How much of the heart is.
Yeah, good point. So if there's a blockage at the beginning of the LAD, now that's going to affect the entire anterior wall of the left ventricle. So that could cause a cardiac arrest quicker. But as far as it being infarcted, the clot happens. Now you've got less, you don't have blood flow going to the ventricle. How long does it take before that muscle dies? I don't know if I could give that a number.
I'm just curious.
All right, the second one is fibrotic tissue. Fibrotic tissue is scar tissue. So when you have cardiac conduction spreading to muscles and the electrical conduction going through dead muscle tissue, it's going to take longer. And that's why the EKG tracing looks different or the QRS looks different. If there's fibrotic tissue, it's going to take longer for the conduction to go through. And that's why the QRS is wider. Does that make sense? So dead muscle tissue, fibrotic muscle tissue, it just takes longer for the cardiac conduction to get through that type of muscle. And that's why the QRS will be wider. And the third one is an electrolyte imbalance. So when there's an abnormal amount of potassium, calcium, sodium in the body, it can lead to irritable ventricle, and the ventricle starts firing for no reason. So when there's an ectopic focus initiating an impulse, that's going to cause the QRS to be wide. So the QRS starts normal from the AV node and it spreads through the right and left bundle branch, through the Purkinje fibers, you get a really nice looking QRS. But if you're low on potassium, so you have a really low potassium level, now the muscle becomes irritable and somewhere in the ventricle can say, oh my gosh, I'm feeling really irritable, and it can start an impulse. Now the impulse starts from this ectopic area or abnormal area. And when the conduction spreads throughout the ventricles, it's spreading abnormally, and it's going to cause a wide QRS. Okay, so kind of simple. Abnormal, you're going to get a wide QRS. Dead tissue, fibrotic tissue, you're going to get a wide QRS. Okay, now we're looking at intervals. So when we're looking at the PR interval, we're measuring from the beginning of the P wave. So as soon as the P wave leaves baseline, we start measuring the PR interval. And we measure to the beginning of the R wave. So if there's a Q, a little deflection there, we stop right there. And that's all those little boxes are considered part of the PR interval. It represents the time that it takes for the atria to depolarize and the impulse to be sent to the AV node and the His Purkinje system. And it doesn't tell you normal, but the normal PR interval occurs between 3 and 5 little boxes. So if everything is going normally in the heart, it's going to take 3 to 5 little boxes for the SA node to send a signal to the AV node and the ventricles. If the PR interval is less than 3 little boxes, that gives us a clue that it wasn't the SA node that started the impulse. The impulse started somewhere closer to the AV node. So does this make sense? If the PR interval is too short, that tells us the impulse originated closer to the AV node. Why would an impulse originate closer to the AV node? It's an abnormal or ectopic site. Okay. And then if you have a really long PR interval, we know that the impulse has to travel through dead muscle tissue and it's going to take longer. So why do we have a longer PR interval than 3 to 5 little boxes? We know that the conduction is going through infarcted tissue or dead tissue. So necrotic means dead. So infarct, what other terms have we used? So infarcted tissue, necrotic tissue, the same thing. It could also mean that the AV node isn't acting right. So a defective AV node. All right, so when you're looking at the PR interval, we start counting as soon as the P wave leaves baseline, and we finish where the QRS begins. And this has got a little Q wave. And when we see that there's like 5 boxes here, 2 boxes here, that's 7 boxes, almost 8 boxes. So we know that the PR interval is longer than it's supposed to be. So we'll come back to this when we talk about heart blocks. Okay, and then look here on the right, you see the P wave and where it leaves baseline, and then where the Q wave begins. So 1, 2, that's a close one. That's almost 3 boxes, not quite. So why would the PR interval be so short? And the answer is, instead of the P wave starting at the SA node, the wave started somewhere closer to the AV node. Why is this? What's that? It can be complete. Like all the atrial muscle can still depolarize. It's because it's peaked. No, that's not what I read in the textbook. And then for the upside down P wave, why would it be upside down?
So before it's the atrial is the impulse generated from the bottom of the atrial.
Yes. So it's upside down because the conduction began close to the AV node and then spread upward throughout the atria. That's not normal, right? It's supposed to start at the SA node and go down the atria to the AV node. But what if the impulse starts close to the AV node? And now when the atria depolarize, the bottom of the atria depolarize first, and then finally the top of the atria depolarize. So the atria depolarizing bottom to top, it's going to make an upside down P wave. And the next is the ST segment. The ST segment is normally even with the baseline. If it's depressed or below the baseline or elevated above the baseline more than 1 millimeter, and 1 millimeter is one little box, it's an indicator of myocardial ischemia or myocardial infarction. So here's normal, where you see the ST segment is at the baseline. And here you see the ST segment is not at baseline. You can tell baseline by looking at the overall, like where the P wave is, the QRS begins at baseline. But then when you look at the ST segment, it's much lower. So all of these are showing ST segment depression. None of them are showing ST segment elevation. So have you heard the term Stemi? Did I tell you this already? If I'm repeating myself, you can tell me. Oh, okay. So STEMI stands for ST segment elevation, but it could be depression also. It doesn't have to be elevation. So ST segment elevation is where the STEM comes from, the E. MI is myocardial infarct. So if somebody's having a heart attack and they have a STEMI, that means they were able to look on the EKG and diagnose that they're having a heart attack because the ST segment is not at baseline, it's above the baseline or below baseline. And then the T wave is normally elevated. If it is upside down or inverted, it's indicative of myocardial ischemia. Inversion occurs due to the lack of oxygen, which results in leaking of potassium from ischemic tissue. And when potassium leaks, I guess that's what causes it to look inverted as it's repolarizing. So here's a normal T wave and then an inverted T wave. And why would it be inverted? And it's because of muscle damage, potassium leaks, and that's what causes the upside down look or inverted look. The QT interval, if you measure from the beginning of the QRS to the end of the T, normally that should happen in, I don't remember the amount of time. Almost QT interval. Obviously, I don't ask this on the test. No, I don't have it written down either. Oh, it says it on the slide. QT interval is 0.36 to 0.44 seconds. If there's been an MI, it takes longer. If it's really short, it could be because of digoxin toxicity, or it could be too much calcium in the body, hyperkalemia. Okay, so that was it for going through the waves. And now we begin with the arrhythmias. It's 11 o'clock. Do you want to take a break now? Yeah. All right, 10 minutes. Okay, so we're going through arrhythmias that develop above the ventricles. So that would be the atria, the sinus node, and then anything else in the atria that can go wrong. First is the normal sinus rhythm. So this is what you call a normal rhythm. So if you're taking your exam next week and you look at the rhythm and you go through the steps and everything is normal, and instead of calling it normal, you have to call it 3 words: normal sinus rhythm. So you can't just say it's normal because it's marked wrong. You have to say normal sinus rhythm. So a normal sinus rhythm tells us that the rate will be between 60 and 100 beats per minute. The rhythm will be regular. So the distance between all the R waves will be the same. The P waves are normal. They're all going to look alike. You're going to have 1 P wave before each QRS. So when we start getting into arrhythmia, sometimes you see 2 P waves before you see a QRS. So just 1 P wave, a QRS, that's normal. The QRS complexes are normal, meaning less than 3 little boxes, and they all look alike. The PR intervals are normal, so 3 to 5 little boxes. So if you see all of these on a strip, then you're going to come to the conclusion that you're looking at a normal sinus rhythm. And here's an example. So this is a 6-second strip. 1, 2, 3, 4, 5, 6, 7. So there's 7 R waves in 6 seconds. What is the rate?
70.
Very good, 70 per minute. Now we look at the distance between the R waves. Looks like a little over 4 boxes for each one. So we come to the conclusion, and then you guys can use a piece of paper and mark on a piece of paper 1 set of R wave distances, and then compare that to the other R waves, or there's calipers in the drawer if you want to use the calipers. So they're all the same distance apart, so we call that a regular rhythm. The next thing we look for are P waves. And do we have P waves? And is there 1 P wave before each QRS? And there is. Then we look at the PR interval, and it should be 3 to 5 little boxes. So we begin counting where the P wave leaves baseline to where the QRS begins. And here it looks like 4 little boxes. So that's normal. Then we look at the QRS, beginning of the Q, or beginning of the R wave to the end of the S wave, and that should be less than 3 boxes. In here, it looks like 2 boxes, and they're all the same. So the QRS is normal. So the normal rate, it's a regular rhythm. We've got P waves. Our PR interval is normal. QRS is normal. We call it a normal sinus rhythm. And that's how we're going to go through every strip that we look at. We're going to use that same criteria to decide what we're looking at. The first sinus arrhythmia is when the rate is really slow. So sinus bradycardia is when you have everything looks normal, but the rate is less than 60 per minute. Call that sinus bradycardia. So it's possible for somebody to have sinus bradycardia, and that's their normal rhythm, especially athletes, high cardiovascular training. Their ejection fraction is huge. So their heart doesn't have to beat as many times per minute to have a normal cardiac output. One contraction could be like 130 mLs versus somebody who has a 60 ml volume ejected from their ventricle when the heart contracts. So a large amount of volume ejected from the ventricle, the heart doesn't have to pump as many times per minute. So they'll have a resting heart rate, 48, 50 per minute, and that's completely normal. That doesn't have to be treated with anything. It's only when the heart rate is slow and the patient is considered unstable. That's when treatment is necessary. So what does it mean to be unstable? Oh, it doesn't tell us. It says describe what symptoms a patient has with an unstable heart rhythm. And did I write it down? Oh, it's on the next slide. So if they have a slow heart rate and it's unstable, they will have hypotension. So their blood pressure is going to be lower than 100/60. So that's considered hypotension. If they have an altered mental status, so if you don't have a good cardiac output reaching the brain, then the person's mental function declines. And you'll notice that they're lethargic, not responding quick enough. That's a sign of altered mental status. That's a sign of not having enough cardiac output. Another sign of being unstable or symptomatic is having chest pain. So hypotension, altered mental status, and chest pain. And checking for low blood pressure, if you don't have a blood pressure cuff, how can you tell if the person has a good cardiac output? Okay, a thready pulse, very good.
Color of their skin.
Color of their skin. And what else happens to their skin if they don't have a good cardiac output? Cold and clammy. And clammy means wet, right? Okay, very good. So cold, clammy skin is another symptom of not having enough cardiac output. All right, so what can cause a sinus bradycardia? Why isn't the heart pumping faster? Since obviously the patient needs to have a faster faster heart rate. The first one, it says SA node disease. So remember that SA node is fed by two different arteries, right? It can either be fed by the right coronary artery, it can be fed by the circumflex artery. But what if that artery gets blocked? Is that going to cause the SA node to not function correctly? And the answer is yes. So that's why what it's saying when it says SA node disease, lack of blood flow to the SA node will cause a malfunctioning SA node. So myocardial infarct kind of goes along with what we were just talking about. If your coronary artery becomes occluded, it's going to affect the SA node. If a patient is taking beta blockers for hypertension, sometimes the medication that they're prescribed causes the heart rate to be really slow. So beta blockers like Inderal, I don't know if you've heard of any of these. No? Inderal. What is another one? Okay. So propranolol, I think, is the generic name, and Inderal is the proprietary name. That's the only one that I know of. There's also, I mean, Inderal also blocks the beta 2 receptor sites. And if you're giving a patient Inderal to get their blood pressure down, and then you try to give them a breathing treatment, it doesn't help because the medication they're taking blocks the beta 2 receptor sites also. So that's one of the problems with Inderal. So there's one that's specific for just beta 1. We don't know the name of it, do we? Atenolol, maybe? I don't know. I'm guessing. Another cause of bradycardia is hyperkalemia. So too much potassium in the body will cause a slow heart rate. So if a patient is symptomatic, we want to treat them. Somehow we want to get the heart rate to be faster. What do? There's a medication that you can give called Atropine. And the way that Atropine works is it blocks the parasympathetic system. Okay, so for atropine, I wrote down atropine blocks the parasympathetic system. And the parasympathetic system slows the heart rate down. Do you remember that? Okay. Well, if you block the slowness, it's going to increase the heart rate. So I wrote, it blocks the slowness of the heart. This will cause the heart rate to increase. So atropine blocks the parasympathetic system. It blocks the slowness of the heart. And this will cause the heart rate to increase. The next drug mentioned is epinephrine. So epinephrine, oh, I missed one. So what you need to know about epinephrine, pardon me. It's a beta 1 agonist. So it'll stimulate the beta 1 receptor sites on heart muscle. That's going to make them contract more forcefully. It's going to make them contract more often. So beta 1 stimulant. Epinephrine also has other receptor sites that it activates. Beta 2. So epinephrine was like the first bronchodilator ever used. And yes, people who with asthma were always having really fast heart rates. They were always really shaky because there's also receptor sites in skeletal muscle, so they're really shaky. So side effects of epinephrine. So you have to know that epinephrine stimulates beta 1 and beta 2 receptor sites. It also has alpha 1 constricting properties. So that's why when you give vaponephrine to a patient who has stridor, because the alpha 1 receptor sites are stimulated, it'll cause the vessels in that area of the upper airway to constrict, and now you have less swelling. So the alpha 1 constricting properties will decrease swelling of the upper airway. Am I telling you something that you're familiar with already?
Yes.
Okay. And what else to know about epinephrine? And then you also have to know that it's short acting. How long is the duration of action?
Epinephrine or racemic
Epinephrine. Tijen? Yes, very good. 5 minutes. So every 3 to 5 minutes during a code, if epinephrine is warranted, it's given that often because that's how long epinephrine lasts. It's quickly deactivated in the body. Okay, and the next treatment for a slow heart rate is a pacemaker. So a pacemaker is an external device, and we have notes or slides coming up on it, so you can write down notes at the time. But it's an external device that will stimulate the conduction system of the heart. If the SA node isn't working, then the patient needs a pacemaker, and then the pacemaker will stimulate the conduction system. Okay, when you're looking at the strip, this is 6 seconds. What is the heart rate? Yeah, so you saw 4 R waves multiplied by 10 and you got the heart rate. Pardon me. So a heart rate of 40. Does everything else look normal? So are they the same distance apart? By eyeballing it, you can say yes. So we did the rate. Is it regular or irregular? Are there P waves? Is there 1 P wave before each QRS or more than 1 P wave? 1 P wave. Is the PR interval 3 to 5 little boxes? Yeah, it looks like exactly 5 boxes, right? So that's normal. What about the QRS? Is it less than 3 little boxes? Okay. So everything is normal. It's just that the heart rate is slow. So we come to the conclusion we're looking at sinus bradycardia. Okay, so this is the first algorithm that I'm showing you, and it's for sinus bradycardia, or for a heart rate less than 50 per minute. What do you do? So it has the branching logic. So first thing you do is make sure the patient is breathing okay. And if they're hypoxemic, you give them some oxygen. At what point are they considered hypoxemic? Down how low? So heart rate, I mean, PaO2 less than 100, but if it's 90, is that hypoxemia? 80?
Below 80.
Less than 80?
Yeah,
Okay, and what would the oxygen saturation be?
80s, 92, isn't it 60 to 90? Yeah. So. She's saying 60 millimeters mercury for 100%.
Oh, yes, yes, very good. Yeah. And on the pulse ox, it reads 2% higher, so it'd be 92%. So PaO2 of 60, 92 on the pulse ox. So looking at the Acls protocols, it looks like they're treating O2 sats that are less than 94%, which would mean 93%, which is a little bit higher than what we're used to. I've been telling you all semester, keep your sats between 92 and 98. That way you're not over oxygenating, you're not under oxygenating according to the oxygen dissociation curve. You're giving enough oxygen to keep the hemoglobin saturated. So 92%. Now in ACLS, I'm seeing less than 94%, start the patient on oxygen. So that would be a 93% saturation. So we're going to do a mega code starting probably after next week. And I'm going to ask you, what is the patient's oxygen saturation and are you going to put them on oxygen? So if you say 92%, 93%, I'm good with either one of those. Start them on oxygen. Use a cardiac monitor to identify the rhythm, start an IV, do a 12 lead if it's available. Consider what's causing it. So is there hypotension, altered mental status, signs of shock we talked about with the cold, clammy skin and low perfusion, chest pain? Does the patient have acute heart failure? How are you supposed to know that? If you say yes, now the patient is unstable. So now you want to treat that. So how do you treat it? So here it tells you atropine. If atropine doesn't work, consider starting a pacemaker or dopamine. I didn't talk to you about dopamine or epinephrine. I guess now is a good time to mention dopamine. You heard about Levophed, I guess, for raising blood pressure. Levophed is a vasoconstrictor. So if a patient's blood pressure is low and you constrict the vessels, you're going to create more resistance in the vessels and the blood pressure goes up. So Levophed and dopamine work pretty much the same. So let me type that in. So dopamine, Levophed is indicated if the patient's blood pressure is low, then they need to get those drugs. So what if the patient does have a slow heart rate, but they have a good blood pressure, they're mentally alert, answering questions, they've got good skin color, they have no chest pain, and they're not in heart failure? What would you do? Just monitor. Very good. Okay, that was it for sinus bradycardia. Now we go into sinus tachycardia. So anytime the heart rate is more than 100 per minute at rest, so not more than 100 per minute while you're running down the street, but you're sitting in a chair and your heart rate's more than 100 and everything else is normal, you're considered to have sinus tachycardia. So even a heart rate of 101 is considered sinus tachycardia. Up to 160 per minute. So why 160 per minute? Why isn't it sinus tachycardia if your heart rate is 180 per minute? You know, very good.
I'm just putting it, it would just be because it's more, what's the word? It's more dangerous once it goes past 160. So isn't it like called something else for a different reason? Because your blood can't, or your heart can't keep up with the amount that it's pumping. That's called something different.
Okay, so if your heart rate's faster than 160 per minute, there isn't much time for the ventricles to fill with blood and your blood pressure drops. Yes. But does that explain why the rate stops at 160 and it's not a higher number? So the SA node, when stimulated, can only fire for adults. It fires up to 160 per minute. Children, I think it's 180. Infants, it's 220. All right, so SA node only fires 160 per minute. Have any of you been exercising and you notice you get a heart rate of 180? And so I don't know why they're saying it stops at 160. So I know when I see my daughter exercising, she always has a heart rate of 180. So I'm just telling you textbook. Textbook says SA node can fire as fast as 160 per minute. That's why it's listing it here as sinus tachycardia. If the heart rate's faster than that, it's considered another type of tachycardia, supraventricular tachycardia, and that's probably next on our slides. So how could it be that we're laying in bed and our heart rate is fast? Why does that happen? And it says it can be from pain. When we're in pain, it causes the heart to beat faster. If we are stressed, if we have anxiety, the heart's going to beat faster. A fever, you can see when your patients are having a fever in the hospital, you're going to see their heart rate's higher, their minute ventilation goes up. And then all of a sudden it breaks. You see them sweating a lot, and then they stop breathing as much. The heart rate comes down. So you can see when they're spiking a fever. Hypoxia can cause an adult heart to beat faster. So if tissues are not getting enough oxygen, there's a feedback that the heart needs to be faster to get more perfusion to the tissue. If there's sepsis, a massive infection in the body, another way the body responds is a fast heart rate. And if the heart is failing and the ejection fraction is low, the heart rate beats faster to compensate for the low ejection fraction. Okay, so here is the, I don't know, is that a 6-second strip? Yes, it is. So what's the heart rate? Very good. Is everything, is it a regular rhythm? Are there P waves? One before each QRS? All right, so when you look at this, if you say, oh, look, there's 2 P waves. Before you can call this a P wave, you've got to, it has to come after the T wave. So you see the T wave first, and then anything that follows is a P wave. So that first upward deflection is your T wave, so QRS T, and then the next wave would be a P wave. Is the PR interval normal? How many boxes? Can you tell from where you're sitting?
2.
Yeah.
Like 1, 2, 2.
So beginning of the P wave. So you start counting here and where the QRS is.
Yeah. 3, 4.
Yeah, I would say around 4 also. Very good. Is the QRS normal? It's like 2 little boxes. If you look at where it begins to leave baseline to where it returns to baseline, looks like 2 boxes. And there's more. A wandering atrial pacemaker is not really important for respiratory. Let's see, does it show a picture? Does it look like the P waves are different from each other? So check out all the P waves. This one looks peaked, this one looks small, this one looks inverted. So when you see P waves are looking different from each other, that tells you that there's different areas initiating the impulse. Not real important. And a PAC, not real important unless after you've had your 3rd cup of coffee, if you feel something in your chest, like your heart's pounding, and then it just stops, you're probably having some PACs from all the caffeine. Premature atrial complex is an irritable area, initiates an impulse in the atria. Wow, it looks like it's got all the combination of a student, doesn't it? Hopefully not tobacco. Hope you guys don't smoke.
There are people. My
It's
sister had an RT
very
and you wouldn't touch it.
It is such an addictive drug. It is so hard for people to stop, even when their lives are at stake. They cannot stop smoking. Yeah, it's sad. Very addictive drug. And are there respiratory therapists that smoke? Unfortunately, yes. It kind of helps now that the campuses are smoke-free, because they were going outside and smoking during their shift. Now that they can't smoke at all on hospital grounds, it kind of forces them to not have a cigarette until they leave. All right, and then compensatory versus non-compensatory pause, not really important. But if you see like a normal rhythm but right here you see nothing. So in this strip, if you look at it, you say, you know what, it looks irregular. Okay, are there P waves? Yes. PR interval? Yes. QRS, everything looks good except for this one. Impulse begins earlier and then all the rest are on time. So when you have a premature contraction coming from the atria, it's called a PAC. After it occurs, then the SA node kind of resets itself and then starts normal again. Not important for respiratory therapists, but sometimes I just want to expose you to things so it sounds remotely familiar if you hear it again. But as far as this being on the exam, no. All right, and then SVT is supraventricular tachycardia. So supra means above the ventricle. So there's a rhythm initiated above the ventricle, so somewhere in the atria, somewhere above the AV node, and it's causing a really fast heart rate. But it's so fast, we can't really tell where it's originating from. We just know it's above the ventricles. So this is a common one. Okay, so I'm looking at my notes and that's all it has. It has a reference back to what I was talking about with the SA node. This came from the ACLS book. It says it's widely believed that the SA node can fire only so fast, an upper limit of 160 per minute in adults. However, each person has a built-in maximum. So I guess that explains why you could be exercising and have a heart rate of 180 when you're exercising and it's completely normal. So I just wanted to share that with you. All right, so for SVT, the impulse originates above the ventricles. The rate is fast, 160 to up to 250 beats per minute. You don't see the P waves, they get buried under the T wave. You're unable to evaluate the P wave or the PR interval. And then there's different names for SVT. So supraventricular, above the ventricles. It can be referred to as atrial tachycardia. And now I need to tell you what PAT is. PAT stands for paroxysmal. I'll tell you what that means. Paroxysmal atrial tachycardia. Paroxysmal means sudden onset. So the person's laying there and all of a sudden, boom, their heart rate goes up to 200 per minute. And within a minute, it goes back down to normal. It's like a sudden onset of a really fast heart rate and then back to normal. So paroxysmal means sudden onset. Okay, so the rate is extremely fast, and this is where counting the number of boxes between the R waves can give you a quick reference. Where's one that falls right on the line? Here's one. So if the heart rate was here, it would be 300. If it was here, it would be 150. So the heart rate's between 150 and 300. So like 225. The heart rates are like 225 per minute. It's a regular rhythm. We can't see the P waves. So we do see one positive deflection, but that's the T wave. So you can't really see the P wave because everything's happening so quick. QRSs are narrow. And that's important to know because if the impulse starts above the AV node, your QRS is going to be less than 3 little boxes. I should write that down, right? Because that's really important. When you're looking at the QRS and the rhythm originates above the ventricles, your QRS is going to be small. Oh, actually, I said that already, right? You have a really fast rhythm. How do we know that the rhythm is starting in somewhere in the atria? And the answer is, oh, because the QRS is normal. All right, I'll make it a question. So I wrote down, how do we know the impulse originated somewhere in the atria? And the answer is because the QRS is normal.
And if it originated above, the QRS is shorter.
So QRS is wide if it starts in the ventricle, and it's normal if it starts somewhere in the atria. So wide in the ventricle, narrow if it started in the atrial, if the impulse started in the atria. I think we talked about this already. So atrial tachycardia, SVT, same thing. The rate's really fast. The impulse originates from an ectopic focus in the atrium. Why couldn't it just be an extremely fast sinus tachycardia? If the heart rate's 250 per minute, and it's so fast, we don't know where the impulse started from. How come it can't start from the SA node? Very good. So somewhere in the atria is initiating all these impulses. So that's the ectopic focus. And we don't see the P waves. What does paroxysmal atrial tachycardia mean? Sudden onset. Very good. It might be a short burst or stays in SVT. Here's a really fast heart rate. How fast is it? So you counted 18? Yeah, so heart rate's 180. But on here we can see the P waves. That's pretty cool.
If it's not irregular, like if it's even, can we just half it and count half and check it by 2?
Yes. And how do you know where half is? Yes. So there's a line every 15 boxes. Chris?
I've seen this a bunch of times. We try to use adenosine shock the heart and then we can see the underlying rhythm. You really can't tell what's going on. That's really fast. And it will usually just happen for a moment, but then we'll have the rhythm, the strip printing the whole time on the delivery truck.
Excellent.
So we've got a short part of it that'll have to show.
Ah, okay. Yeah, because adenosine has a really short half-life, doesn't it? Like 12 seconds or something like that.
Sometimes it'll shock them out of the SVT. More often we'll just see for a second. Sometimes we won't even get to see the underlying rhythm.
Oh,
And we tried it a few times, and then, it doesn't work.
very good. What is an ectopic focus? You know a little bit about an ectopic focus, right? So an ectopic focus is an area in the heart other than normal that initiates an impulse. So it's an area in the heart other than normal that initiates an impulse. Got that? And then this irritable focus can be caused, and I'll tell you the causes. Low oxygen can cause an ectopic focus to start an impulse. So low O2 can make the muscle tissue irritable. Low potassium or ischemic heart tissue. All right, so a really fast heart rate, what can cause it? The first one listed is sick sinus syndrome. There's something wrong with the SA node and it just keeps firing. Congenital cardiac disorders can cause SVT also. One of them that are common in this list is the Wolff-Parkinson-White syndrome. So I want to explain Wolff-Parkinson-White syndrome. So as the cardiac conduction is going down the atria, sometimes there's some conductive tissue that follows back up to the SA node. So impulse will go down, it'll follow this new path, it'll go back up to the SA node and cause it to fire. And then as the impulse spreads down, it goes back up and causes it to fire. So it gives a really fast heart rate. And the treatment for it is to have an ablation where they'll cauterize that area of the heart to stop that from happening. But it's not real common in kids, but it can happen quite a bit. So I just wanted to point it out, because I know when you're doing your pediatric rotation, sometimes you hear about a cardiac ablation occurring, or a patient has Wolff-Parkinson-White. So that's why I wanted to point it out. So when you do your pediatric rotation, you'll understand. Go ahead.
Also, a faulty pacemaker.
Can do the same thing.
I've seen, we had a guy come in and his heart was racing because it was a short in his pacemaker.
Oh my word. Oh my gosh.
Yeah.
Pacemakers aren't supposed to have faults.
No, this thing was crazy. It was beating at like 180.
Wow. Wow. All right, so when you're studying for your exam, having to memorize a huge list, I don't want you to do that. So causes of SVT, if you can remember an MI, if you can remember Wolff-Parkinson-White, that's good enough. I don't want you to think you have to memorize these long lists. And then having too much digoxin can cause SVT. Have you learned about digoxin? What is it?
Isn't it a contractility drug? I don't know. It's for people with congestive heart. We did. Kim went over it.
I think it was like too much calcium.
Digoxin. Oh, too much calcium can cause SVT. Yeah.
I think I read that somewhere.
Yeah. Can you remember where you read that? Because that happened to me.
Really?
Yeah. I was told that, oh, when you have to take 1,000 milligrams of calcium a day. So I was taking 1,000 milligrams of calcium a day. I had no idea why I had this fast heart rate all the time. Then I found out, well, if you're taking calcium, you're supposed to take the same amount of magnesium. When I stopped the calcium, my heart rate went back to normal. But I went to a cardiologist. They said, there's nothing wrong with you. I said, could it be too much calcium? Oh, I've never heard of that. So I thought that, well, maybe it was just me. Maybe I'm an anomaly or something. So this is the second time I'm hearing that.
Yeah,
That's
I don't know
interesting.
where I heard it. It could have even been a TV show. I don't know. It just popped in my head. I heard it somewhere.
Wow.
Grey's Anatomy or something.
Is there anything about digoxin that's going to be on the test? Because I don't really remember that drug.
So it helps with the contractility of the heart,
Just that.
and it's used for somebody in heart failure.
See,
So I'll put that in the chat.
I don't know if it's PowerPoint from last semester, but it's-
And you guys had to learn so many drugs. I don't expect you to remember them, and I don't mind, reviewing them at all. So if something doesn't sound familiar, let me know. Yeah, when I started in the profession, before your parents were born, there weren't that many medications, so to get through respiratory school, there was like one mode of ventilation. Pressure control was just coming out. There was very little that had to be memorized. So I memorized it from many years of working with it. Patient after patient comes in heart failure and they're on digoxin. And then they forget how many to take. They take too many. They come in with dig toxicity. If you're working in the ER, you see it all the time. So many years of exposure helps you to remember the drugs. But to go one semester, learn hundreds of drugs and expect to remember all of that? No, that's not going to happen. So it's going to be the repetition that makes it stick.
How about for the board exam? They don't ask about them.
They do. So you'll review them again for the boards. Most of them, it's not dosages that you have to remember. Respiratory drugs, yes. But you have to remember the dosage for digoxin or for Levofed, no.
It's just what they do and what they're for.
Yes. At the bottom. Hyperthyroidism. So having an overactive thyroid gland can cause a person to have a fast heart rate. All right, so if the heart rate's really fast, how can we get it to slow down? So before giving the drug adenosine to slow down the heart, it says to attempt vagal maneuvers. A vagal maneuver is what you do if you're constipated, you're sitting on the toilet and you're trying to push. That's a vagal maneuver. What's another example of a vagal maneuver? Bearing down, I guess, is another term for it. So if you increase the pressure in your thorax, that's a vagal maneuver. And sometimes that can slow down a really fast heart rate.
Like when you prep for the reps.
Yes. What is it, like 20 to 25%? There was a study that showed up. 20 to 25% of SVT can be converted by doing a vagal maneuver or a carotid massage, where they massage the carotid artery for like 10, 20 seconds, and then that slows the heart rate down. So you try those first. If it doesn't work, there's a drug to give, and the drug is adenosine. And it's given intravenously. So the first time it's given 6 milligrams. Within 12 seconds, it's already metabolized by the body and activated by the body. So if it's going to slow down the rhythm, you'll know like within 12 seconds whether it worked or not. If it doesn't work, then you give a second dosage of 12 milligrams and see if that converts the rhythm. If that doesn't work, the only other thing that you have left is to shock the heart with a voltage. And it's called cardioversion when you use a small amount of voltage. So the thought is if you apply a small electrical shock to the heart, it's going to stop the cardiac conduction altogether. Then when cardiac conduction starts up, it'll start up normally. So that's the assumption. And hopefully it does. Sometimes it goes to asystole, but that's why you're always at the bedside when they're doing a cardioversion. But it's thought to stop the entire conduction system and let the SA node start doing its thing and taking over. Is there anything else I have to tell you about that? No. So did you write down vagal maneuvers? Because I didn't put that in the chat.
Oh, it says it on there.
What is a vagal maneuver though? Bearing down, yeah. Carotid massage also. Yes. All right, that's all I have. All right, and then the next thing talks about cardioversion, and then we'll break for lunch. So what is cardioversion? It's a low voltage electrical shock applied to the precordium, which depolarizes the entire myocardium and allows normal impulses to take over. So you didn't have to write it, it's right there. A cardiac defibrillator is used, and it'll synchronize the delivered shock to the R wave of the EKG tracing. Do you know why that's important? Fibrillation, ventricular fibrillation, yes, very good. So it has to be synchronized so the shock doesn't get applied at the wrong point in time during the relative refractory period. 50 to 100 joules is the normal amount of energy for a cardioversion. So during a cardioversion, having a shock to the heart is really painful. And if the patient is awake and alert and the shock is given without them having sedation, they scream bloody murder. So it's really painful. So of course, if a cardioversion is being planned, you need to sedate the patient first. And what they typically use is Versed. One of the side effects of Versed is its amnesia. It erases the memory of the person during the time that it's given. So they experience pain, but they don't remember the pain when they wake up. So Versed is given during cardioversion. And I just have some notes written. So respiratory is called to stand by for cardioversion, just in case the rhythm converts to asystole or another lethal rhythm. It's part of the respiratory therapist's responsibility for airway. If the patient's not breathing, you start bagging. And then of course, no pulse, start compressions. A lot of sedation is given, usually Versed, because it erases the patient's memory of the procedure. But Versed may suppress respirations. So make sure during the procedure that you're monitoring O2 sats and end-tidal CO2. How can you shorten that? Respiratory, standby, cardioversion, patient not breathing, start bagging, no pulse, start compressions. And then write down that you want to monitor O2 sat and end-tidal CO2 during the procedure. So monitor end-tidal CO2. Monitor end-tidal CO2 and SpO2. So it looks like we have 2 more rhythms after lunch. And I need you to demonstrate your amber bagging technique, bag valve mask technique. And I need you to demonstrate compressions after lunch. Okay. Is 30 minutes enough for you guys? Do you want to do 45 or 45? All right. So come back at 10 to 1. All right, so, and there's an atrial arrhythmia called atrial flutter, and the atria literally flutter. So if we could take the heart out of somebody's chest that are in atrial flutter, and we look at the heart, we're going to see it fluttering. So it's because of a rapidly firing ectopic site somewhere in the atria. It depolarizes the atria 250 to 350 times per minute, and they look like a sawtooth. Do you guys know what a saw looks like? You ever seen a saw?
No.
Most people don't see saws these days. But how about a bread knife? Where it has that scallop looking edge? That's considered a sawtooth look, I guess. So that's what it looks like on the EKG. Do the ventricles respond 250 to 300 times a minute? No, they don't. So let's see what it looks like. All right, if you're just looking at all of these little upward deflections, does it look like a bread knife or a saw? Serrated, yes, serrated edge. SERRATED. All right, so every time there's a P wave, it's because the atria are depolarizing. So you get all these P waves, but they don't always make it through the AV node to the ventricles. So you notice a bunch of P waves and then a QRS. Sometimes it's regular, sometimes it's not regular, but that's your telltale sign. It's just seeing all of these P waves. It's from cardiac disorders. Is there anything here to memorize? Not really. Can it happen with patients that have COPD? Yes. Can it happen with low oxygen in the blood? Yes. Digoxin toxicity, and then there's a bunch of other things.
So you said we don't have to know
No,
Just see if we
no, I don't want you to have to memorize all these lists. So noticing cardiac disorders, good enough. Something's wrong with the heart. Possible COPD, just because somebody has COPD, it can lead to atrial flutter. Hypoxia and digoxin toxicity, and that's it. All right, the next arrhythmia is called atrial fibrillation. So there's a little difference between fluttering, where it's almost like A frequent contraction is considered a flutter. Fibrillation is you don't really see a contraction. It's more like a quivering, like a shaking. Yes, fibrillation is more like a shaking. So the atria are not contracting at all. They're just quivering or shaking. That's atrial fibrillation. We show it to you and then I'll come back and go through the list. All right, so just upon a quick glimpse, you notice that the rhythm is very irregular. It's so irregular that your eyes notice it like right away. Can you see how there's a real long pause, another pause? This one's a short pause, a long pause. I shouldn't call it a pause. I should call it the distance between the R waves. So it's a very irregular rhythm, and that's what'll clue you to a possible atrial fibrillation, irregular rhythm. Then the next thing you know is you don't see a nice P wave before each QRS. Here you might say, oh, that looks like a P wave, but you don't always see it. Like here there isn't one. And that's because the atria, instead of depolarizing normally, they're not depolarizing normally, and it's causing them to quiver or fibrillate. All right, now let me go back to the list. So the distinguishing features of atrial fibrillation are that the rhythm is irregular. The P waves appear as a chaotic baseline. You almost think you're looking at artifact. That's what the P waves look like. It's caused from several irritable areas in the atria that discharge impulses at a rate of 350 or more per minute. And all of these impulses create quivering or fibrillating in the atria. And then the AV node gets all these impulses, but the AV node doesn't respond and send the impulse forward to the ventricles. So it says the AV node is refractory to most impulses. Do you know what that means?
Non-responsive.
Very good. It's not responding to most of the impulses. All right, so that's atrial fibrillation. And then let me show you a picture of it. So this shows a normal heartbeat. Heart rate is 60 per minute. So you see the SA node fire, and then you just see some lightning go through the atria to the AV node and then through to the ventricles. And then in atrial fibrillation, do you see how they have these little things lighting up in the atria? Those are all the irritable areas in the atria that are initiating impulses. And when they do, it makes, some of them will cause the AV node to send the impulse to the ventricles, but it ends up being an irregular rhythm. And it's showing it to you here, where you don't really see P waves, and then you just see a very irregular rhythm. So chaotic baseline, you don't see P waves, and the rhythm is irregular. If you see those three things, you know you're looking at atrial fibrillation. From cardiac disorders, and then it's frequent in patients with COPD that have right heart failure. I do want you to remember that. So atrial fib, you're going to see a lot because you're going to be dealing with a lot of patients with COPD. So you're going to come across atrial fib a lot. So how do you slow down this chaotic rhythm? With beta blockers again. So we talked about using beta blockers to slow down a fast tachycardia. And it would slow down a fast atrial fibrillation also. So the beta blocker drugs that we talked about, we mentioned propranolol. atenolol. There should be 2 A's in there.
What about metoprolol?
Which one?
Metoprolol?
You guys seeing that a lot in your patients?
I
You have?
That's a beta blocker.
How do you spell it?
NETO.
METO? Okay, okay. So that's another beta blocker that's specific for beta 1 receptor sites. Metoprolol.
Question on the previous PowerPoint slide. My PowerPoint has other things on there that aren't on your previous PowerPoint. Should I just ignore the things?
Yes, can you cross them off, please?
Yeah. Okay, thank you.
So sometimes the AV node is just responding to too many of these impulses, and the patient is an atrial fib, but it's really fast. And the beta blockers are not working. So now what? Now they need to be cardioverted, and hopefully that'll stop all of the irregular rhythms coming from the atria and reset the SA node to start over. So if beta blockers are not working, then they have cardioversion. Oh, I have one more thing for you to add to your notes. Patient needs to be prescribed an anticoagulant. And then I'll explain why. Did you write that down? Anticoagulant as another way of treatment. So when the atria are quivering, it's possible for blood to be in the atrium and not get pushed down into the ventricles. So the blood kind of pools or stagnates in the atria. And when blood holds still, it starts to form blood clots. So patients who have atrial fibrillation frequently end up having strokes because of it. So how do you prevent them from having a stroke with these blood clots being pushed through eventually? Like they don't just stay in the atria. Eventually they do make it into the ventricles, and then they can become a pulmonary embolus, or from the aorta travel into the brain and become a stroke. And the answer is putting them on anticoagulants when they're diagnosed with this arrhythmia. So anticoagulant to prevent blood clots. Is that good enough, or do you want to write down other notes? Like blood clots form because the atria are quivering, or blood flow becomes stagnant because the atria are not contracting normally? Would that be a better way to say it? All right, so I put blood clots form because atria are not contracting normally. So when they're quivering, it's possible for the blood to not flow into the ventricles. Question, did you? Yes. Yeah, so you have a test coming up next Tuesday? And to review for the test, shall we meet maybe on Thursday? Guys, does everybody have Thursday off, or maybe I can record a review?
Let's record it.
Okay.
Yeah, we could always do that.
Wow, a lot of you work on Thursday. No, so by the time we all get home, maybe at 4 p.m. do a Zoom on after clinicals.
Yeah, I think a lot more.
Okay,
So you're still gonna record it, because I have class on Wednesday, so. Yeah, after clinical.
you go from clinical to
I do.
class?
Oh,
I could join it on Zoom.
so Zoom.
Oh, can you really? All right, so Wednesday and Friday, Which day?
Both day, Wednesday and Friday.
No, she's
Saying
asking
what
what
day
is
is
better.
better.
Friday? Either or for me, so
Yeah,
just
either.
whatever works better for everybody.
When,
It's
Wednesday?
recorded, right? Yeah, you recorded.
Friday's better.
I prefer Wednesday.
Wednesday.
Guys, Friday's perfect.
Oh.
All right, so only one vote for Wednesday? Everybody else votes for Friday?
I vote for.
I don't
And it
vote
doesn't
for-
matter, just
I mean,
record?
Wednesday,
Yeah,
I
just
possibly evening too.
Just
so.
recorded.
Oh,
But then if it's at least recorded Wednesday, then we
Yeah,
can watch it
it's
Thursday.
recorded, so that's
Yeah.
ah, okay.
Where, like, if we wait till Friday and then we're working the weekend.
That's true, yeah. Smart.
So Wednesday.
Yeah, so tomorrow at 4, right?
Okay.
I know, it's okay.
Okay, another algorithm that's used for ACLS. So patient has a really fast heart rate. What do you do? Again, to give them oxygen, put them on a monitor, start an IV, do a 12 lead. Do they have symptoms? Like, are they unstable? Yes. Wow, it goes right away to synchronized cardioversion. And down here, it says vagal maneuvers, adenosine, beta blockers, calcium channel blockers. So this is a summary of what we've already had in lecture. I don't need you to add any other information to it. Amiodarone we talk about in the next week. All right, now it's quiz time. So I am going to show you a rhythm. Where did I put it? Here. No, not there. All right, so let me pull it up again. Slow. No, so I'm looking for a list of everything that I have stored in the cloud. I usually click on this, it opens the cloud. Maybe it's here. Oh, here we go. Okay. I'll call out the page numbers so you guys can write it down and quiz yourselves before the test. All right, the first one is, so this is Bruce Shade, second edition, page 272. No, so it's off a little. So 271, 272, number 9. So you have to go by the actual textbook page, not the page from the PDF. So page 272 in the textbook and then number 9. Okay, so we're looking at a rhythm. What is the first thing we do? Okay, so the rate and the rhythm. What is the rate? Rate is 90, okay. Is it a regular rhythm? Does it look like the R waves are the same distance from each other? Okay. Are there P waves? They're big, but there's P waves. And the PR interval, is that 3 to 5 small boxes?
Yeah.
Okay. And the QRS, is it less than 3 boxes? So you begin here and you count to, I guess this is baseline right here.
Like 2 boxes.
2 boxes, okay. So what rhythm is that? Yes, very good. Normal sinus rhythm. Everything's normal. It's normal sinus rhythm. All right, now go to page 272, number 8. Okay, what is this one? What is the rhythm? Yes.
Bradycardia, SR.
So you would call it sinus bradycardia. Okay, the next one is page 274, number 14. Okay, how fast is the rate?
130.
So heart rate's 130, everything else is normal? So sinus tachycardia, very good. All right, the next one is page 276, number 22. No, they all look regular. And there's about 4 boxes between each one, so it's a regular rhythm. Then we look at the rate. And the rate is 80 per minute. We've got P waves. PR interval is about 5 boxes, that's normal. QRS is less than 3. So what conclusion do we come to?
Normal sinus.
Very good, normal sinus rhythm. Good job. Now we go to page 313. So 20. $305, 313. Number 3. Is it regular or irregular? It's irregular. So the distance between the R waves are different. So we know it's an irregular rhythm. The rate is 90 per minute. Very good. Do we see P waves? Yeah, it looks like a lot of artifact, like a chaotic baseline. So very good. Atrial fibrillation. It's irregular. We see a lot We don't see P waves, we just see a chaotic baseline. And that tells us it's atrial fibrillation.
So do with 313 or 342 number.
It's the textbook page that I'm telling you. Let me show you. Like right here, it says 313. So I'm telling you the textbook page.
Okay, 313 and 3.
Mhm. And then 314, number 8. What do you think about all of those P waves? Does it look like your sawtooth pattern or serrated edge? SVT? No, heart rate's 130, no. Yeah, so all those P waves, making it look like a serrated edge or the blade of a saw is the clue that you're looking at atrial flutter. And then page 315, number 12. Does everybody agree? Okay, so it's really fast. We see one little positive deflection between the QRSs. Is that a P wave or is that the T wave? That's the T wave. So we're not seeing P waves. We're seeing a really fast rate. What is it, over 200 per minute? We see that the QRS is normal. So we know that it conducted through the AV node into the ventricles normally. But somewhere up in the atria, it's generating really fast impulses. So that's why we call it supraventricular. It started above the ventricles and it's really fast, tachycardia. So supraventricular tachycardia, SVT. Page 316, number 15. That looks regular. How fast is the rate?
160.
It hurts your eyes.
Number 16.
Okay, so here it lands on a solid line. So 300, 150. It's somewhere between 150 and 300, so maybe 225. All right, that's pretty fast. Is this sinus tachycardia? It's atrial tachycardia. Can we call an atrial tachycardia SVT? Yes. Page 316, number 16. Oh, that's where we are. I'm seeing lots of P waves and it's irregular. So lots of P waves, atrial flutter. Yeah. Page 319, number 49.
This might be a dumb. What's the difference between atrial fibrillation and atrial flutter? Is there like, is that just there's not as many looking like artifacts, like how the other one was that we said was atrial fibrillation?
She was saying the fib like was just kind of like a shakiness, but the flutter is actually like different flutters. And that's what makes it look different.
I think the biggest difference is flutter will be regular, then it's going to be irregular rhythm.
For the most part, yes. I know that the one that I just showed you is an exception because it's irregular and it's atrial flutter. But the difference is with atrial flutter, you can see P waves. Atrial fibrillation, you don't see P waves. So that's the big difference between the two. So 319, number 49. Maybe that's a typo. Number 29. All right, what do you think of this rhythm? Is it regular or irregular? It's irregular. Very good. So do we see P waves? You might argue that once in a while you see a P wave, like that might look like a P wave, but not all the time. So we see an irregular rhythm. We see a chaotic baseline with an occasional P wave. Yeah, an inverted P wave. So we come to the conclusion that it is Brent, what do you think? You don't know? Okay. Yeah, so irregular rhythm, we don't see P waves. We're looking at atrial fibrillation. So irregular rhythm, we don't see P waves, atrial fibrillation. Okay, and number 31. What about this one? Does that look like a sawtooth pattern or serrated edge? Lots of P waves. Atrial flutter, very good. So that serrated edge look, lots of P waves causing the serrated edge look. We're looking at atrial flutter. Okay, 3 more. Page 320, number 32. Well, that's where we are. Yes. So fast rhythm. It's regular. Is it too fast to be sinus tachycardia? 1, 2, 3, 4, 5, 6. Yeah, a rate of 200 per minute. So 200 per minute, that's faster than the SA node can fire. But we know the impulse started somewhere in the atria because we see a normal QRS. So we're just going to call this supraventricular tachycardia. The impulse originated somewhere in the atria, and we actually see P waves, but who knows where in the atria those P waves started. So atrial tachycardia or SVT. Okay. Page 324, number 46. Am I beating a dead horse by showing you the same one over and over again? What is this? If it was fibrillation, we wouldn't see P. Very good. Atrial flutter.
What is the difference between atrial tachycardia and sinus tachycardia?
It's faster. Atrial tachycardia is faster than 160 per minute.
I thought that was the supraventricular.
Oh, atrial tachycardia, supraventricular tachycardia, you can use those names interchangeably.
Okay, that's nice.
Which one's interchangeably?
Atrial tachycardia and supraventricular tachycardia can be used interchangeably.
On the test we're having next week, is it like, are we gonna fill in the blank stuff like we usually do in the test?
Yeah,
So are you gonna expect us to write out the names fully, or can we abbreviate it like AFib?
I would like for you to spell them out as much as you can. If you don't remember and you put the abbreviation, I'll decide if that's okay.
Figured I'd ask you.
Okay, and then page 326, number 54. So here we've got a normal rhythm, and then all of a sudden, boom, 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 we have a really fast rate. What is that word that we use to describe sudden onset? Paroxysmal. Yeah, paroxysmal means sudden onset. So they call this PSVT. Sudden onset of a really fast heart rate, SVT. PSVT. Okay, that's it.
The fill in the blanks would be identifying the different ECGs. Would we have any short answers?
Yeah, so you have to interpret EKGs. So there'll be several arrhythmias on the test. You have to identify whether it's regular or irregular, what the rate is. You have to measure the PR interval. You have to measure the QRS. And then you have to state what the rhythm is. So yeah, I give you extra time because that takes a while to do that. Yeah, and then after this test, you don't have to write down how many everything is. But for this test to start off with, you do. And then future tests, you'll just recognize a rhythm and put the rate down and what the arrhythmia is.